We will give everyone a minute or two to join in and start at 12:02 promptly. I'll mention this before we begin as well, but this is a rerun of the meeting that we held in conjunction with the community conference last week. And so if any of you were on the combined coordinator investigator call last week, this is exactly the same material. You do not need to attend twice. So please feel free to use this hour for other purposes. All right, well, I have 12:02, so let's go ahead and get started. Thank you all for joining our Improve Care Now community conference. If any of you just hopped on, this is a rerun of the material that was presented at the Improve Care Now live online community conference last week. And so if you attended that combined PI coordinator session, you don't need to attend this one. And it's because these slides were presented last week that the date at the bottom says September rather than October, but happy October to everyone. So I'd like to start by just welcoming you all and thanking you for continuing on what has been a very long journey with us and with the combined project. Believe it or not, November 1st marks the beginning of our 6th year on this odyssey together. So thank you for your perseverance and tenacity and flexibility and patience, and especially over the last 6 months, we've all had to use as much flexibility and creativity and patience as possible. And I think in the end of the day, we owe it to our patients and our families and ourselves and our entire Improve Care Now community to be able to provide strong evidence rather than opinion to inform some of these really important treatment decisions that our patients and families must make. The agenda for the next 45 minutes or so, we'll spend some time talking about study progress and where we're at with recruitment and retention. You all asked in the months leading up to this meeting that we present to you all a lot of data, and we will do that. We will tell you the patient characteristics and outcomes and adverse events experienced by participants that have been enrolled to date. We'll talk a little bit about missing visits and missing data. We're going to talk a little bit about the last 6 months of COVID and really what we've accomplished together to try to keep the combined ship sailing despite a international pandemic. A couple odd tips and reminders, not odd, but actually super important, but miscellaneous tips and reminders. We'll talk about the year ahead. And we should have a little bit of time at the end of the hour for open discussion or any comments or concerns that any of you attending this meeting would like to raise with us. In terms of site activation and recruitment, we currently have 33 sites that are active across the board. We have randomized 300 participants. The breakdown of enrollment per year is shown here. This year in particular has been a tough year, largely due to the COVID pandemic, but I'm pleased that we've still managed to enroll 26 patients this year. 35 sites have recruited at least one patient, and so it really has been a large sort of multi-center team effort here. Cincinnati Children's Hospital of the King's Daughter and UNC are the lead sites in terms of randomization, with upwards of 20 patients enrolled in each of these 3 sites. Our overall project recruitment is shown here. The blue line represents our current recruitment, and the green line was our targeted recruitment. As you could see, we had hoped to have recruitment completed a year or 2 ago, but it's been a slow and steady recruitment up until this point. I don't think we will ever make our current target of 425 patients with the time allotted, but nevertheless, this is the largest randomized trial ever done in pediatric Crohn's disease, and I think we still stand to learn a lot from our work, and more on that in a little bit. This slide here shows our recruitment by site. And again, I'd like to challenge all sites listed on this slide to see if you could get 1 or 2 new patients in the months ahead as clinic operations are resuming, as endoscopy and colonoscopy operations are resuming, as research operations are resuming across all of our sites. Let's sort of end the year of 2020 with a bang. If we all do our fair share and recruit 1 or 2 more participants, we will get really close to our needed recruitment targets. A little bit about retention. And so of the 300 patients that were randomized to date, 30% are still active in follow-up and on study drug. Another 17% are active in follow-up but have stopped study drug, either because they have met a primary endpoint and per protocol stopped study treatment and remain sort of in follow-up off drug, or because of a non-medical reason, the patient or family decided to stop study treatment on their own without experiencing a study endpoint. And those patients we will continue to follow off treatment and be quite vigilant as to whatever study endpoints they may meet during the course of their follow-up tenure with us. 35% of patients have completed follow-up, and so we are done with them. 3% of patients, or a total of 9 patients, withdrew from the study almost immediately after consent and prior to receiving their first shipment of medication. According to our study protocol, these patients will not be included in our modified intent to treat analysis. Another 25 patients, or 8%, withdrew after the first medication shipment, and they will be included in our analysis and will have contributed time prior to withdrawal of consent. 6 patients were lost, 6% of patients have been lost to follow-up, and 1 patient had an invalid consent. So in total, of the 290 patients that will be included in our modified intent to treat analysis, the overall dropout rate is about 15%. Given that patients move or patients are lost to follow-up from clinical care for other reasons, or decide to find a new physician or treating center and move their care elsewhere, 15% dropout in a pragmatic trial is pretty reasonable and on target with what we had been expecting. Interestingly, of the 43 patients who have dropped out, either withdrew consent or were lost to follow up, 23% of those met a primary study endpoint prior to dropping out. And so in our time to event analysis, these patients are incredibly helpful to us. 58% of patients had at least a year of follow-up prior to dropping out, and so made a major contribution prior to dropout. 42% contributed less than 12 months, and so it's unfortunate that we lost those patients so early on. But a good chunk of patients, even though they withdrew from the study or were lost to follow-up, still will contribute meaningfully to our combined analyses. You all might be wondering, what does our study population look like so far? And I should stop for a second. We have a small enough group today. If you all have any questions as I'm going along, then either unmute and just go ahead and ask them, or put something into the chat box. And Margie and Anne, if you see anything in the chat box, please stop me along the way and let me know that there's a question. We can address it as we go along. So in terms of our first 300 participants, 66% are male, 34% are female. And again, this is smack on as to what we were expecting. Not only does pediatric Crohn's disease have a male predominance, but many female patients, particularly teenagers of childbearing years, may be sort of inappropriate to consider methotrexate treatment on. The mean age of our enrolled participants is 13.9 years, and the racial distribution is shown at the bottom here. While this is a primarily Caucasian population, we do have 10% Black or African Americans, and a smattering of patients from other racial groups or even multiracial patients. Ethnicity, only 3% Hispanic or Latino. And I think this is a combination of perhaps willingness to participate in research studies in the Latino population, as well as a difficulty in accommodating Spanish-speaking patients at many of our study centers, where many centers are just not equipped with bilingual research staff to not only obtain appropriate informed consent in Spanish, but to continue follow-up procedures in a sort of dual language modality. Time from diagnosis to study enrollment. So the mean is less than 10 months. And so we really have been recruiting a newly diagnosed patient population. And so unlike most adult studies and even the adult commit study, which was a study of anti-TNF alone or in combination with methotrexate, we are not looking at experienced patients, but we are looking at patients that, by and large are newly diagnosed and naive to most inflammatory bowel disease and Crohn's disease treatments. Steroid use at the time of randomization, 40% were using, 58% not using. In terms of the anti-TNF mix, 71% infliximab and 29% adalimumab. And that mix has held steady since the beginning of our study recruitment several years ago. The mean SPC-DAI score at enrollment is 14.5. And so you all probably know that the cutoff between inactive and mild disease is a PC-DAI score of 15. And so that kind of characterizes our study population. Another way of looking at disease activity is by physician global assessment. And what we see is that 23% have quiescent disease and 33% mild disease. So more than half of our population with quiescent or mild disease at the time of enrollment into the combined trial. I will remind you that many of our patients are enrolled in combine either after they've been started on corticosteroids or potentially after the first 1 or 2 doses of anti-TNF. So a lot of that pretreatment has influenced their disease activity at the time of combined enrollment. In terms of perianal disease, 29% have had perianal disease at the time of our enrollment. Mean SED rate, 21.2, so kind of on the border of normal and elevated. Mean albumin, 3.8. Mean hemoglobin, 12.1, so maybe slightly on the anemic side. And CRP greater than twice the upper limits of normal, 22%. Outcomes. So overall, 80 patients have met a study endpoint out of the 290 in our analysis population. And so that amounts to 27% of patients have already experienced a study endpoint. We'll go through this in the next slide, but as a reminder, our study endpoints sort of indicate lack of achieving induction of remission, loss of remission after initial induction, prolonged use of corticosteroids, or sometimes intolerance or toxicity from either the anti-TNF or the study medication. 110 patients are still in follow-up and at risk for meeting an endpoint. And so, I would suspect that if 27% of patients have met an endpoint and, another chunk are still in follow-up, when all is said and done, probably about 35 to 40% of our enrolled population will meet an endpoint over the course of their follow-up with us. We have we have recorded and certified 88 outcomes across these 80 patients. This next slide here shows a time to event analysis. In other words, this is the time from enrollment into Combine until the first outcome that each patient meets. And in this slide here, patients are censored or removed from the at-risk population when they are lost to follow-up, or at the time that this data was cut. If they had only had 6 months of follow-up at the time this data was cut, then we only show 6 months of them, and then they'll become one of these dots on the screen at the 6-month mark because we don't know what will happen in the future. So 100% of patients at the time of enrollment are free of meeting an outcome. That's by definition. And over time, patients will experience endpoints. What we see here is that for patients who are followed for 2 years, about 70% or so have event-free survival, or 30% meet a endpoint. And of course, that we now have optional follow-up for up to a 3rd year, which is why my prediction is that somewhere more than 30% will reach an endpoint by the time we're done with their follow-up. This is just a breakdown of the study endpoints that participants have met and for which sites and PIs have certified. So 15% the primary endpoint met was discontinuation of study drug for toxicity, 15% discontinuation of anti-TNF for lack of effectiveness, 15% hospitalized for an IBD-related reason after week 25, or sort of the 6-month mark, 12% discontinuation of anti-TNF for toxicity, 11% discontinuation of study drug for lack of effectiveness, and the other outcomes are shown at the bottom of this slide, as well as the top of the next slide. It looks like there may have been a comment in the chat. Let me see. Someone asked, were those 13 patients all the same patients? No, so again, the 88 outcomes detailed on this slide and the next slide occurred over a total of 80 patients. And so some patients met two outcomes simultaneously. For example, a patient who had abdominal surgery after week 25, more than likely they were also hospitalized for that surgery after week 25. And so largely it's the bottom line here and the middle line here that are the two outcomes that those 8 patients co-experienced at the same time. Adverse events. So across our 290 participants, sites have recorded a total of 671 adverse events. We will ignore the other for a moment. All of the adverse events here are adverse events that we've attempted to collect from sites discreetly. These are events that have been called out in the package inserts for the anti-TNFs as well as methotrexate. And so we have boxes to check on the adverse event form for patients who experience those. Everything else gets recorded as a other. And so 41% have had other adverse events, whether it may be stubbing the pinky toe, or a fractured femur, or who knows what. This is a good opportunity for me to remind sites, and I think Anne will do this later. If a patient has the flu, please do record this as an adverse event, but record it as an infection. And we'd love to be able to collect discrete adverse events as much as possible. Really use the other for things that are not described in these categories here. But you'll see that nothing really new is popping up. We know infection, we know nausea, vomiting, we know abdominal discomfort are all sort of commonly experienced adverse events in patients on anti-TNFs, or patients on methotrexate, or patients with underlying Crohn's disease. So I'm going to switch gears a little bit and talk about how we're doing as a combined group with follow-up and data collection. So this slide here shows our follow-up visits as a percent of what we would expect. And so you'll notice that we expect 300 screening visits because we've randomized 300 participants. And as we go down, we expect fewer and fewer because some patients have been enrolled relatively recently, and we wouldn't expect them to have follow-up, sort of beyond week 3 or 4. Other patients we know have withdrawn or have been lost to follow-up, and therefore we don't expect those visits to have been recorded either. And some patients completed the study early, and we don't expect those visits either. But you can see that after week 14, we're getting somewhere about 80% of the visits that we would have expected to get. And we understand that not every patient comes into clinic on a quarterly basis, as was written into the standard of care protocol. Patients go away for summers, patients are at college, scheduling difficulties occur, whatever it may be. But all said, making 80% of the visits is, I think, relatively okay. Please do try to get study visits in whenever possible. If a study visit does not happen, this needs to be reported as a protocol deviation, albeit a minor one and one that we totally expect. The visit windows are but one another, and there shouldn't be out of window visits. So if a visit happens, try to assign it to one of the study visit windows if and when possible. And of course, these days, one of the silver linings of telehealth is that, even for those patients that we can't drag in for a face-to-face visit, it's a lot easier to schedule a telehealth visit. So hopefully, over the months ahead, we'll do even better with capturing 80% of visits according to the required timeline. A little bit about data completion. And again, we've shown a similar slide in prior versions over the years. We're doing really good with data completion on the combined forms. As a whole, sites are less robust with entering data in the Improved Care Now registry. And so the fields that are highlighted in green are the fields of data that we usually get from the Improved Care Now registry, which is just not as complete. I used to highlight these in yellow to call this to your attention as deficiencies, but rather I've highlighted it in green today to show how much progress we've made over the last year. And so we've recovered almost 10% of missing hemoglobins, almost 10% of missing albumins, almost 10% of missing SED rates and C-reactive proteins. And so Anne and Margie and Catalina have been querying many of the sites, pestering many of the sites over the last couple of months. As a community, the sites really have responded well, and we've recovered a lot of this data that was otherwise missing. And so that is really awesome. In terms of adverse events, I've already reported to you all that we've collected 671 adverse events. 50 of these are still listed as ongoing and have been ongoing for more than 1 month. 18 of these events have been ongoing for more than a year. If a patient has diabetes as an adverse event, then we understand that that's going to be ongoing because it's a chronic illness. But a lot of the other adverse events will quickly subside. Maybe the patient had nausea and an adjustment was made to the treatment and the nausea has subsided. Please review those adverse events that look like they're still open, and if they've completed, sign them off as being completed. Even the left broken toe, after 6-8 weeks in a boot, generally can be marked as resolved. And so you can look at the adverse event listing report. You can look at those that don't have an end date or don't have a outcome that is resolved, particularly those where it's ongoing. And it would be great to sort of update these reports to indicate that the AE has been resolved, if indeed that is the case, and add a end date to that, as well as the date that the SAE ended. In terms of PRO forms, boy, we have collected a lot of PRO reports over the course of follow-up. And this slide here shows our PRO completion rates. As you know, we expect 6 PRO reports over the course of follow-up, and we are getting somewhere between 80 to 90% of the expected PRO reports at the required visits. This is just a quick plug that we are now able to collect PROs remotely, and we'll talk about that in a little bit. So it gives us another opportunity and another modality to collect PROs, even for patients who aren't coming to clinic for office visits. All right, Combine and COVID-19. I think this is an area where we all really should be giving ourselves a huge pat on the back. So just to recap, a little over 6 months ago, the world as we knew it really turned upside down. COVID-19 shut down clinic operations almost entirely. Since that time, I think most people have been working from home, both clinical staff as well as research staff. over the last month or so, we've maybe seen a bit of a return to actual near normal, but even that near normal includes a fair amount of remote working. Many research studies were shut down across all of our universities, but I think for the most part, combined operations were able to continue as combined follow-up was really nested within everyday clinical care, and as good GI docs and clinicians and centers, we worked hard to follow our patients throughout this pandemic. The single IRB approved a modified sort of protocol and telehealth checklist that we really worked closely with all of the sites in mid-March and through April to implement at participating sites. And here's what we've accomplished. Amazingly, we've randomized 12 patients since the COVID era. And so thanks to CHKD, Emory, UNC, Michigan, Rainbow, Wisconsin, Dayton, and Lurie for randomizing patients during this exceptionally difficult time. We have logged 290 combined visits over the last 6 months. And so telehealth is working for our sites, working for our patients, and working for Combine. We've collected 38 PRO reports electronically. I think we probably could do better than that. Since the biobank reopened, we've shipped and received and processed 8 sets of biosamples. 444 non-visit labs have been entered. Our study pharmacy has sent 242 shipments. And so, roughly each patient who is still in follow-up has received 2 shipments since the combined pandemic began. And what do you know, that math works out perfectly because the pharmacy is scheduled to ship medicine to participants on a quarterly basis. So I'm going to switch it over to Anne for a little bit to go over a number of FAQs, reminders, and other tidbits. And I will come back to wrap things up at the end.
So thanks for joining us today, everyone. We appreciate it. And so I just wanted to go over some of the things that we get emails about most often. And so our number one is, what do we do once our patient has stopped taking study medication? So the big thing is, please don't withdraw your patient. We will continue to follow them off study medication, as you know. So what we do, we continue to follow them for all their study visits. We continue to collect the PROs and the biosamples. We will record all the lab results. And really the only kind of 2 things that we do a little bit different is for adverse events. We only need to collect and record them for 2 weeks after their final dose of study medication. After that, you don't have to record the AEs. And for our female participants, we will follow them for 16 weeks after final dose, checking to make sure that no one has become pregnant during that time. We will continue to collect all the SAEs, so please continue to send those in regardless of if they are on study meds or off. I see a question here. Where do we email pro forms to again? I can send that to you. So if you're talking about the electronic forms, I can send you the link if you need that. And you will email the completed, if you have a hard copy of the form, those will be sent to Children's Hospital of Philadelphia. So I can get that address for you if you need it. Another question that we get quite often is that I don't see a provider review section anymore. How come I can't sign off? And this happens when a patient goes off study medication. So that provider review section disappears. So the provider no longer has to sign off on the study visits. However, we really want the providers to continue to review. So you will get the reminder to review it. You just don't need to sign it. And this is to ensure that the clinicians are reviewing the data entry, make sure everything looks good, and that you're still maintaining oversight of your patients. You will need to continue to sign off on completion and early termination forms, though, however. So continue to do that as needed.
Just a reminder to the clinicians, every time a patient has a visit, it's a really good opportunity to just sort of, go through that mental checklist of, have there been study outcomes? Has there been an adverse event that patient experienced? Was a colonoscopy done, and is there an opportunity to update the colonoscopy form? Was a calprotectin done? Is there an opportunity to update that calprotectin lab, any sort of infliximab or adalimumab drug levels? Anything that may not be super duper easy for your coordinator to glean from a review of the chart that the clinician may have an awareness of. Work with your coordinator to make sure that all of that information gets captured. I know that as a clinician, a lot of things happen by telephone or conversations with the nurses. And unless it's really clearly sort of documented in the chart and in a place that the coordinator knows to look for it, work with your coordinator to get that information. Don't assume that your coordinator can read your mind. It needs to be very clear for them to find it. So we send those emails to you on a regular basis just to sort of jog your memory. If there's anything that you know about that's not recorded, study medication changes, anti-TNF medication changes, dose changes, interval changes, any of that. If it doesn't, intermittent use of corticosteroids over the interim, all that stuff, glance through the combined report. If it's not there, work with your coordinator to enter. All right, and I think I got to advance the slide.
Okay. My patient isn't able to come in for their last visit. What do I do? We have 3 different scenarios that we work with. If it's at all possible to get them in shortly after that visit 10 or visit 14 window closes, please try to get that last visit in within 6 to 8 weeks. This can be counted as the last study visit. You would log it as a minor visit deviation, mark the patient as complete, and you will be paid for the final visit. It's helpful if they come in during the visit 11 window and they have missed visit 10, to enter this data in the visit 10 window if they are completing the study. So just keeps everything kind of nice and neat, and we can see that they were able to get visit 10 data in. Another thing to do is, especially now with these days with telehealth, is to call, talk to the family, see if you can get a telehealth visit set up, confirm and record any outcomes that the patient might have. Do whatever you can by telephone, email, whatever it takes, and then go ahead and mark that patient as complete as well. The third scenario is if you have tried calling, they're not returning phone calls, any of that, can you go ahead and advance the slide so I can make sure I give it a complete, yes. So you've tried calling, you cannot reach them, they will not call you back, they have moved out of the country, whatever it is, you would have to mark them lost to follow up. So complete the early termination form, with the date of the last contact that you had, either by telephone, telehealth, or face-to-face, with the date that you know with confidence whether or not any of the outcomes were met. And if outcomes were met, please ensure that the dates and outcomes are recorded and contact me to get your certification form. We are maintaining that form for every outcome that we have, every first outcome. So now we're going to go into some of the reminders of things that we're seeing. Maybe things are cropping up a little bit more. So just as a reminder that you don't have to record any AEs for this list of events here. These are all expected. They kind of go along with Crohn's disease. You are welcome to record them if you want to, but it is not a requirement to do that. So if, I know we've been sending out lots and lots of queries, so if you need to save your time, this would be one place to save some time by not writing down every single AE. And everyone has received their email so far asking about a ballpark date for the last study. We've been seeing more and more of these completion early termination forms are being checked as unknown for the date of the last methotrexate placebo dose. We have 22 completed people that were unknown and 33 early term. So we've, those emails have gone out, the queries. We respect that it's often extremely difficult to be able to ballpark or guesstimate a date. Sometimes you are, if you're able to track down other dates, such as maybe an outcome and, you know, methotrexate was stopped during that time of a specific visit. Sometimes, especially with the early terms and loss of follow-ups, that people just simply disappear and it's impossible. So we're just asking you to look, check through the EMR, see if you can find any signs to be able to do a best estimate of when that last dose may have happened. It doesn't need to be exact. We're just asking you to get close. And if it is truly unknown, then just let us know, and we have that marked, and won't bother you about that again. Another thing that we're seeing more often is that the study medication return form is not being used. So this is an example here that I pulled from a patient who had 9 visits. They were marked completed, and the study medication return was never completed. So this should be done at each visit. Ask the patient's family to return any medication that they may have. If they don't return it, then you can mark no on this. So that's absolutely fine. And then the reason why the medication wasn't returned. So a lot of times I hear no tablets were returned. The patient forgot to bring them in. Very common. If we have that down on this form, great. We know what happened. For this patient here, we have no idea what's going on with them. So it's really helpful if you can complete this form after every visit.
Just a couple reinforcing comments. First is the main purpose of this form is to encourage all of the sites to collect unused study medication from participants and log the number of pills that are collected and destroyed, because we can use that as a measure of adherence. And so going to be really important for those types of analyses. We don't have detailed surveys to patients about adherence. We don't have detailed surveys to sites and coordinators about adherence. but we do know the number of pills that the pharmacy dispenses. It would be great if we have the number of pills that are untaken. We can assume that the other pills have been taken by the patient and use that in analyses of adherence. Secondly is, we want to do everything we can as sites to make sure that there isn't study medication, just sitting in the cabinet of our participants' homes. Methotrexate for the patients who are assigned active therapy is a teratogenic medication. Many of our patients live with mothers or other family members that are of childbearing years. We don't want sort of methotrexate to be sitting around the house for months and months and possibly taken by a non-study participant. So please make sure that any unused study medication leaves the patient's house and comes to us to collect, and that we're able to destroy and record that appropriately.
And also in this day of COVID, where patients are being seen by telehealth and not coming in and being able to bring in their study medications, please encourage your families to bring them in once they do come to a face-to-face clinic visit. You can enter the number of tablets over a period of time, so it doesn't have to be associated with a specific drug shipment. Again, you can just kind of estimate the best you can. And I think that there is a limit to the number of pills that you can enter. So go ahead and split those over a couple of different shipments if you're running into that. As you know, everyone has completed the continuing review, so thank you so much for sending in that information to Carrie. I've been going through the deviation log and submitting that as just one large log, and then I've split it up into the sites. So if you would like your electronic version of what your deviation log says, go ahead and contact me. But one of the things that we're seeing a lot is missed visits versus missing data. There's a lot of confusion on what this is. So the IRB approved the coronavirus phone checklist, which means that we know that we're going to have some missing data during this time period. That type of information doesn't have to be written down as missing data. We already know that it is. If you have a telehealth visit, that counts as a visit, so you do not have to count that as a missed visit. So we've been seeing some of those come in quite often too. Missing data, such as the physical exam, you don't need to report that as a deviation. Like I mentioned, any of those types of things, if it's not on the checklist, then we don't have to expect that during a telehealth visit. Now that people are coming in to clinics again, we'll be going back to the old method, but we do recognize that people are still doing telehealth visits. So either way, either do it the COVID way, or if they are in front of you in the clinic, do it the old way, and then you would report any missing data if they were coming into the clinic. If patients are having blood draws at outside labs, this is not considered missing data. Just please ensure that you're getting those labs scanned into your EMR and that those are being entered into the database. And PROs, during this time, these should not be missing. Like Mike mentioned before, we have an electronic link that either the coordinator can do this over the phone with a patient, or because some of the questions, might make teenagers a little antsy, you can send them the link. They can fill it out themselves and then I have all the information right there in the database. So other deviation log items that we're seeing quite often is that the participant is seen outside the visit window. A couple of years ago, we took away the break that used to be between visit windows. So right now, there are no breaks between the visit windows. As you can see, when one visit window ends, the next one begins. So for this example here, if the patient was seen on October 26th, you would mark down visit 2 as a missed visit, and the 1026 visit would go into visit 3. I've heard from several coordinators who are trying to get even more data in, so they'll put, you know, the 1026 into visit 2 because it's close enough. We just want to make sure that the visits land where they are. So if you do get a patient that comes in twice during a window, the first visit will always be recorded as a combined visit, and the subsequent visits within the window would be added in as an additional visit. As mentioned before, PROs can be done, PROs can be done electronically. Don't report as missing data. Contact me if you need to have this link. And as I mentioned, either the coordinator can complete it or the patient can complete it. I check this database about once a week, but feel free to email me if you have a specific patient that you are wondering if they have completed it or not. I can pop into the database and let you know the date that they completed it. I would go ahead and if you are sending the link to them on the visit itself, you can say that they completed the PRO, and then, but please don't send out the $10 gift card or whatever you're doing until you get assurance that they have completed the PRO. Sometimes some patients need to be reminded a couple of times before it's actually completed, and it's quite unusual that if we have someone who doesn't do it after the second reminder. Okay, Mike.
Back to me, and thank you all for staying with us for the hour. I will wrap things up in the next couple of minutes. And so, as I mentioned earlier, we anticipate recruitment through the end of 2020. And so we have 3 months left to get as many patients in as possible. Now is the time for that last push. If each site recruits another 1 or 2 additional patients, you know, we may be able to eke out enough power to get this project done right. Of course, statistical power in the end of the day will depend on follow-up time, what the underlying event rate is, the proportion of patients who meet 1 or more endpoints, what loss to follow-up is, and many other factors. We hope to be able to follow recruited patients for as long as possible. We anticipate that the follow-up will be a minimum of 12 months for each recruited patient, a maximum of 36 months. And we intend to do follow-up through the end of 2021, or potentially longer, depending on when our funding runs out. It looks like there may have been a chat question or two. Looks like Anne is handling those. So how can you help? Again, it's now or never for recruitment, so double down your efforts. Make one last attempt to talk to all of the providers in your division, all the nurses in your division, the rest of the clinical care teams, to make sure that we're identifying all of the Crohn's disease patients who are newly initiating on anti-TNF therapy. Make sure that we approach those patients early. Make sure that clinicians are involved in the warm handoff. Make sure that we have follow-up with patients and reminders up until they reach the time limit of recruiting. For a patient who misses that time limit but is still interested, let me know, and we're happy to make an exception if the patient can be randomized, a couple days after the 6-week mark from anti-TNF initiation. After recruitment, we got to follow these patients super closely, make sure follow-up visits are scheduled at the right intervals, record the follow-up data in both the Combine and Improved Care Now databases, be diligent about collecting PROs and biosamples, record study medication changes, concomitant medication changes, that's starts or stops of corticosteroids, changes in the dose of the anti-TNF or the interval of the anti-TNF, adverse events, labs, colonoscopies, calprotectins, collect and destroy unused study medications, be hypervigilant to identify primary study endpoints, and continue to respond to data queries from Margie and Anne. They're here to help the study, not to pester you. You all know that we are in the process of preparing for our interim analysis. We had planned to do an interim analysis after 76 patients experienced the study endpoint. As mentioned earlier during the presentation, we're now at the 80 mark. So we should be doing that interim analysis. We are working on the analysis as we speak, and we'll be presenting it to the Data Safety and Monitoring Board later this month. Just as a reminder, myself and Anne and the rest of our study team will be blinded as to the results of that interim analysis. So don't say, hey, Mike, what did the interim analysis show? I don't know myself. Statistically speaking, I can tell you that we planned for what we call a stingy analysis, where we would only stop the study early if there is a super clear winner at a p-value threshold of less than 0.005. And why did we plan a stingy analysis? Because we want to run this study as long as possible and not stop early, so that we can do as many sub-analyses as possible, including looking at whether the role of combination therapy is different in patients treated with infliximab versus adalimumab. As a reminder, we had not planned to stop early for futility, again, because of the importance of subgroups and heterogeneity of treatment effect. And of course, all along, we've been doing twice a year Data Safety and Monitoring Board meetings with a plan to stop early for any safety concern that has popped up that is beyond or in addition to what we had already expected. And there's been no reason to stop early for safety. Just a couple of high-level reflections as we reach the end of our time together this afternoon. It's amazing when I take a step back and think about what we have done. It's an amazing amount of work, right? We've randomized over 300 participants. About 50% have completed at least 2 years of follow-up by now. We have recorded over 2,235 total visits. We've collected 789 biospecimen samples. We've completed over 1,000 PRO forms. We recorded 671 adverse events. We've sent and you've responded to thousands of queries for missing data issues. And we've managed to keep the ship afloat in the midst of a pandemic. And so this really has been an unprecedented adventure during unprecedented times. And thank you all. We know it's a labor of love, and it takes a village, including all site coordinators and PIs, and other site staff, MDs, RNs, schedulers, and everyone involved in this. Really a special thanks to Anne, Margie, and Catalina, who have been the glue that has held this project together. And of course, our Cincinnati Children's Hospital Data Coordinating Center. And most importantly, our 300 participants and families who have signed up to be part of a double-blind, randomized, controlled clinical trial of a major therapeutic decision early in the course of pediatric Crohn's disease. So thank you. I know we are just at the top of the hour. I can stay on for a little bit if there's any questions or discussion points, but if those of you have clinic or other meetings to jump to, please feel free to jump off at any point. Feel free to unmute if you have comments or questions, or put them into the chat box. All right, well, hearing none, we will adjourn our meeting for today. And you know where to find me, you know where to find Anne, you know where to find Margie if you have anything you want to discuss at any point in time. We are always available. So thank you all again. And again, 1 to 2 more patients over the next few months. Bye now.